All right, so for those who are on Zoom, if you did not get the QR code scanned, please do that. You don't have to log in if you couldn't hear me before for some poll everywhere questions. All right, so for our learnings today, we're gonna list the major acute and chronic complications from breast augmentation and mammoplasty surgery, contrast breast screening pre and post reconstruction, identify indications for breast reduction surgery, something that we think I feel very not frequently about, which is an important concept. Discuss post-operative care and physiologic impact on post-breast cancer reconstruction patients, and then also discuss breast cancer screening in our transfeminine and transmasculine patients. All right, so we have a question up here. If you guys want to take a look at that and answer it for us. So which of the following is true? Saline implants are used more frequently than silicone implants. Subglandular implant placement makes mammography easier than subpectoral implant placement. Subpectoral implant placement has a higher risk of capsular contraction, or breast implant illness is not recognized as a medical diagnosis. We'll give you guys a couple seconds to answer that. No wrong answers here, but this is some of the information we're going to cover today. All right, so we have a wide variety of responses, which is good. Actually, the true answer is D. Breast implant illness is actually not a recognized diagnosis. It is a constellation of symptoms. So we will go over everything else. Okay, we got one more question for you on the next slide. All right, so this question is, which of the following is incorrect with regards to breast cancer? Patients with a history of breast augmentation have a statistically higher risk of breast cancer. Patients who complete reduction mammoplasty have a lower risk of cancer, and breast implant associated anaplastic large cell lymphoma is mainly associated with textured implants. Yes, I see that. But this is great because I didn't know anything either. So this is awesome. So which of the following is incorrect? Is A, patients with a history of breast augmentation have a statistically higher risk of breast cancer? That is actually false. So we'll talk about the other two. Okay, so our presentation outline, we'll sort of talk about the importance to primary care. We'll talk a little bit about history of breast reconstruction, because I'm always very interested in the history of medicine. We'll talk about breast augmentation. Main things I want you to take away from this is the importance of understanding the type of implant and the placement of the implant. Those are the two big things. What to counsel our patients on, and then I'll transition to Whitney, who will talk about macromastia and breast reduction, breast cancer reconstruction, and gender-affirming surgeries. All right, so what I learned about breast implants, I mainly learned from social media. So I watch a lot of bad TV while running or cleaning or doing other things. And most of what I learned about complications from breast surgery, I learned from sort of shows, some real life reality like Botched, which is a couple of plastic surgeons that take on cases of sort of botched surgeries, mostly dealing with breast implants and rhinoplasties. Nip Tuck is the second one. This was about 10, 15 years ago, not reality show. And the last two are some reality shows online. So why should we care about breast reconstruction in primary care? Patients may come to us with questions prior to breast surgery if they're thinking about this. We're usually the initial point of contact for issues years after you've had a surgery done. So acute issues usually managed by surgery, but then 5 years later, who's dealing with the problems? Patients are coming to see us. And how breast cancer screening changes in patients with breast reconstruction, I think is important to note. So we're ordering the proper screening for our patients. So how common is breast surgery? So this is 2020 data, but this was actually a pretty low reduction. This is also during the pandemic when elective surgeries weren't being done. But about 300,000 surgeries are usually done annually. And 34% or 34,000 of them are reduction surgeries. It's important to note that most women who have a breast sort of surgery will have to have a repeat surgery. So it's about a third of augmentation and half of reconstruction. So it's a lot of sort of going back in. If anyone recognizes this social sort of shot to Sex in the City, This is when Samantha was going to go for her breast augmentation surgery. And if you remember, this is when they found her breast cancer. It was a very interesting sexnicity that had a lot of social medical commentary. So what do we know about the history of breast reconstruction? So I feel like Halsted did everything, and he was actually one of the first people to perform a mastectomy. This was back in 1882 for breast cancer. At that time, the thought was to leave the incisions open and have it heal by secondary intention, and the thought was less breast cancer if that happened. So women were actually very disfigured for the rest of their life after this surgery. But it wasn't until 1955 where people really started studying the psychological consequences of mastectomy and really realizing the effect that that had on our patients. Silicone implants were developed in the 60s. We also did reconstruction after mastectomy, wasn't until 1971. In 1978, we started looking at silicone implants with a submuscular technique, which is the most common today. And then we started looking at taking latissimus dorsi flaps for our patients, so trying to reconstruct breast projection, especially in our patients with mastectomy, using their own tissue rather than implants. And it wasn't until 1998 and the Women's Health and Cancer Rights that actually mandated payer coverage for breast prosthesis or breast reconstruction post-mastectomy. Latissimus dorsi flap. So like I mentioned, I really want you to know type of implant and placement and why this is important for our patients. So there's two major types of implants. There's silicone implants on the left here and saline implants on the right. So breast prosthesis are actually medical devices. So they're actually monitored and regulated by the FDA, which actually leads to a lot of regulation around them in general. So silicone implants were approved a little bit later in 2006 compared to 2000. Silicone, they both have a silicone capsule. So you don't get away from silicone, it's just what they're filled with, whether they're filled with silicone or they're filled with saline. Silicone implants have a more natural feel and a less chance of rippling, a cosmetic defect that I'll show you in a future slide. But saline implants are very easy to be inserted. They can be inserted deflated and then sort of filled up over time. So for my sister-in-law, she has a saline implant after her mastectomy because it's very easily to be expanded. If rupture occurs, silicone implants have to be removed, and we'll talk about the importance of making sure our implant has not ruptured. But if saline implants rupture, it just sort of deflates, body absorbs the saline, you actually don't have to remove anything. And it's obviously very obvious when a silicone implant deflates versus very hard to clinically figure that out on a silicone. 84% of implants in 2020 were silicone, so they're definitely the more popular implant compared to only 16 in 2020. This is a cosmetic rippling effect that you'll see with a saline implant, so you can see sort of those grooves in the side of the breast wall. So placement of the implant is also really important, and I'm going to show you some photos of where it is. So the two options for placement of implant is subglandular, sort of on top of the chest wall musculature, but behind the ductal tissue, or subpectoral. So this is a dual plane implant. So it's sort of partially under the pec major and then half outside of it. Subglandular has no interference with pectoralis function, so maybe better in athletes or anyone who has to do a lot of overhead arm movements. Usually less pain if I'm not sort of placing something under the muscle. I would say cosmetically, more commonly, subpectoral implant placement is used. It has less rippling side effects because it's hidden behind a muscle wall. It interferes less with mammography, and I'll show you why that is in a later slide. And there's less risk for a chronic condition called capsular contraction, which is basically when the body sort of has an autoimmune effect and walls off the implant. It can lead to significant pain and cosmetic deformity in the future. So here's some photos on the actual placement of the implant. So on the lower left, we have subglandular, so on top of the pec major there, but behind the ductal tissue. And then we have subpectoral, so you can see that partially that pec major goes over the implant. And how does that look from a sort of AP view? You can see on the upper right side. So that with a subpectoral placement, a little bit of that implant sort of sticks out on the sort of left outer quadrant there, but very different compared to subglandular. So because these are medical regulated devices through the FDA, there's some counseling that needs to happen from the surgeon prior to implant placement. And so I wanted to go over very briefly what that counseling is. So FDA does have a warning that implants need to be replaced every 10 to 15 years. I will find that most of my patients have not had this done. And so what are the consequences of that? Textured surface implants have been linked to anaplastic large cell lymphoma. We'll talk about the incidence of that in a second in case your patient has questions. And the FDA does give a warning for this concern for breast implant illness, even though there's no actual diagnosis code associated with this concern. They should not be placed in women with active infection, untreated breast cancer, or those who are currently breastfeeding. Safety has not been studied in patients with autoimmune disease. So anyone who has a history of lupus, RA, things like that, the really implants have not been studied in these patients. Psychiatric comorbidity should be under control. There's an age cutoff. Important to note that breast augmentation will not affect breastfeeding. Whitney will contrast that with mammoplasty in the future, and there is no increased risk of breast cancer. So if your patients are concerned about that, statistically, there's no increased risk. The FDA also requires this checklist to go over technically prior to implant. So the importance is not all of the details on this slide. I'm going to go to the next couple slides that sort of show you what the actual statistics are for complications, because I think they're pretty high and it's important for your patients to understand that. So here's the slide of all the potential complications and their risk. So pain, about 36% of patients. Skin or nipple areola sensitivity changes is also about a third of patients will lose sensitivity in their nipples, which is a concern. Asymmetry is fairly common. Impact of aging or weight change on size. Infection, swelling, scarring, hematoma, tissue death, or skin necrosis are all very common. And if you look sort of down here, chronic pain, also possible as well too. The inability to breastfeed, 1.6% of patients, I just told you it doesn't interfere with breastfeeding. This is what the average population, 1.6% of women also just can't breastfeed without implants. So no statistically different than without. So what will you see acutely once your patients have had their surgery? I have many patients who get their surgery done in another country and then come see me after because it's cheaper there. So common things after acute surgery would be bleeding, skin necrosis, seroma, hematoma, or infection. I'll show you some photos of those. And usually this is managed by the surgeon if the surgeon's around. So the top left here will be some skin necrosis, just sort of death of the blood supply. Very common also if you're doing a post-mastectomy because we've taken out all of the ductal tissue and sort of blood supply for that. We have an infection in the second one. And then the lower right-hand corner shows a very large hematoma, sort of on that left breast there, right after surgery. So what are we going to think about chronically? So when our patients come see us years later. So it's estimated that 98% of implants will be intact after 5 years, but only 83 to 85% after 10 years, which is why the FDA makes that recommendation, hey, we should think about replacing these every 10 to 15 years. Deflation of saline implant, no problem. It's going to be absorbed. Obviously, it's going to be a cosmetic defect, but not a harm. The problem is when we have silicone implants, the detection of that is actually very difficult to see. So in 2006, the FDA actually recommended MRI 3 years after implantation and every 2 years thereafter. This was a recommendation that less than 6% of women actually followed through with, mainly for insurance purposes. It's very hard to get insurance to just do screening MRIs for rupture of your silicone implant. In 2020, with the advent of newer silicone implants that are double-walled and less likely to rupture, the FDA changed their surveillance recommendation to include ultrasound or MRI beginning 5 to 6 years after silicone implant placement and every 2 to 3 years after. This is non-contrast breast MRI. You don't need contrast to see if it's ruptured, but clinically less than 50% of silicone ruptures can be detected. So that's why they sort of mentioned doing this further imaging. When you look at plastic surgery data, very few women, less than 10%, comply with this second recommendation. So what happens chronically aside from rupture? So the most concerning thing that has come out in the past 20 years has been this breast implant associated anaplastic large cell lymphoma. It's very rare, okay, super, super rare, 186 cases over 6 years reported. It is associated with 33 deaths though. So it's pretty fatal when you get it. Usually what will happen is 10 to 15 years after your implant, you'll get a sort of malignant infusion around the implant, and that's how they detect it. Usually they'll find this implant or perifluid collection and it's treated with chemotherapy. It's only associated with textured implants for the most part, which we don't use anymore. So if you definitely have patients with very old implants, they're probably not going to know if they're textured or not. The recommendations from the FDA is that if you even have this implant, you just have to be monitored more closely. You don't necessarily need to have it completely removed due to the extremely rare likelihood of this disease, but it's something that your patients may definitely ask you about. The other major issues you'll find is capsular contracture. So it's basically when fibrous tissue forms around the implant, thought to be an autoimmune response to a foreign body in the body. Risk factors will also include smoking, hematoma, or radiation treatment. So your patients who have breast cancer, have a mastectomy, get their implant in, and then need radiation, which is still currently the most common course of treatment, it's much more likely that the implant will have some capsular contracture. This is actually a pretty severe case, but it's something actually we took a look at in resident clinic not too long ago. The entire implant gets basically walled off. It almost feels like concrete. It's very, very painful for the patient, and most of these patients need to have that removed. So breast implant illness, like I mentioned, not a ICD-9 or 10 diagnosis code, but this is what patients may ask you about. Even though it's not an official diagnosis, there's a Facebook group for this condition that has over 170,000 people on it. So it's definitely something that people are worried about. It's thought to be an autoimmune or inflammatory condition. Very vague symptoms: fatigue, arthralgias, myalgias, dry eyes, alopecia, skin rash, Raynaud's, but usually does improve after the implant is removed. So something that your patients may be very concerned about. Unfortunately, we don't have any data on incidence or prognosis. So lastly, when you have a patient with an implant, regardless of who they are, how do you have to screen them? So the presence of an implant decreases the sensitivity of mammogram for breast cancer detection. And it really depends on where you place the implant, and the next slide will show that. But since more breast implants are done with that submuscular or subpectoral placement, it actually makes mammograms much easier. So why is this? So when you order a mammogram for your patient with implant, there's actually an implant order. So you can order a mammogram with implant, and it's because they do an additional view, an implant displaced view. So what they try to do is push the implant out of the way to just basically squish the tissue. So in that middle photo there, you'll sort of look at a compression mammography here. So they're gonna sort of squish the implant down. And then all the way on your right side, you'll sort of see if the implant is behind the pectoral muscle, it's much easier to squish all the ductal tissue and just take a look at the ductal tissue, rather than if an implant is also in there, like in the middle picture, and you're trying to squish everything together, if that sort of makes sense. So subpectoral placement is really the best for mammography detection for the future. Okay, so now I'm gonna transition to Whitney, who's gonna talk about macromastia.
All right, so Miss Dolly Parton is probably the most visible patient with macromastia. Macromastia doesn't have a common set diagnostic criteria. Typically, normal breast development begins in utero, with the largest growth of breast tissue beginning around age 12. Breast tissue is largely influenced by growth hormones that activate the tissue receptors to stimulate development. Most breast development is complete by the end of puberty, and typically normal anatomic boundaries of the breast span from the second rib to the seventh rib inferiorly, and then to bilateral axillary lines, with the medial border being the sternum. The nipple areola complex rests at the most prominent point of the breast mound, which is typically measured at somewhere between 18 to 23 centimeters. Patients with macromastia can have an excess of 900 to 2,200 grams of tissue per breast, which is the same as 2 to 4 pounds of tissue, or the equivalent of the weight of a 2-liter soda bottle per breast. Excess breast tissue is primarily comprised of fibrous tissue and fatty tissue, with relatively small increases in glandular tissue. The etiology of breast tissue hypertrophy is not clear, but there may be a genetic predisposition to an increased presence of receptors that are more susceptible to hormonal surges. There's also some thought that hormonal birth control may contribute, though this has not been well demonstrated. Pregnancy and weight gain are also common causes of hypertrophy. And most cases of macromastia begin in early adolescence, and the presence of true breast hypertrophy development as an adult warrants a malignancy workup. As I mentioned, there's no standard definition or diagnostic criteria for macromastia, but it's generally agreed that a detailed history showing the effects of the excessive breast tissue on the health and quality of life of the patient is sufficient to diagnose. Information such as the current bra size, as there's some literature that points to a guideline of a D cup or higher being inclusion criteria, the degree of nipple ptosis, as well as the presence of strap grooves, are important features. Additionally, patients suffer from chronic pain as a result of their breast size. Many patients have chronic cervical and thoracic pain, as well as headaches. There's a strong possibility for ulnar compression leading to paresthesias and the eventual development of degenerative disc disease due to compressive forces. Discomfort during physical activity should also be thoroughly explored, as 36% of surveyed college athletes report breast injury, which were rarely reported to their providers. Patients may also be asked about chronic intertrigo, maceration, or skin breakdown as a result of their breast tissue or bra fit. And additionally, it's reasonable to also explore the effect of the excessive breast tissue on the self-esteem and body image of each patient. So there's very little information on the best practices for breast exams in patients with macromastia. However, given the amount of tissue that will be needing to be examined, providers should allow for extra time during the exam. An important point of care for patients with macromastia is a proper bra fitting. Breasts have very limited intrinsic support and move relative to the chest wall. It's been shown that as little as 2 centimeters of movement, either laterally or vertically, can cause a patient pain. Bras typically come in 2 different styles: an encapsulation bra, which is worn for everyday use, or a compression bra, which is reserved for physical activity. And there are no standards of bra fit across manufacturers, so obtaining a properly fitting bra is challenging for most. The difference of these 2 measurements, the typical bra size is measured using the chest circumference across the base of each breast and the circumference of the breast prominence. The difference of these 2 measurements is used to determine the cup size. Sports bras did not come into existence until the 1970s after the adaptation of Title IX and the inclusion of more women in athletics. The first sports bra was actually created from having 2 male jock straps sewn together. And while there's an overwhelming amount of options for sports bras, even elite athletes struggle with finding a proper fit. In fact, a survey of 2012 London Marathon participants, 75% of those women reported pain and concerns with their bra fit. In the past few years, there's been a lot more studies into the biomechanics of bras and breast movement, but there's still a significant amount of work that needs to be done. Moving into the treatment of macromastia, typically as clinicians, we always want to start with the most conservative management. However, less than 1% of patients will find resolution of their symptoms with the use of NSAIDs, physical therapy, proper bra fitting, or weight loss. Mammoplasty is one of the most common plastic surgeries, as Elena mentioned, in the United States, and is considered to be the only definitive treatment for macromastia. As there are physical consequences for macromastia, most insurance companies, including Medicare, will consider reductive mammoplasty to be reconstructive rather than cosmetic, which often means that patients can have these procedures paid for. However, payment authorizations often require a documentation of at least 2 symptoms from different body areas which have affected the patient for greater than 1 year. Additionally, there must also be a documented trial of conservative measures, often for at least 3 months. The plastic surgeon's office will then document an estimate of tissue to be removed. This is done using the Schnur scale, which the complicated calculation is put down on the screen. And this estimates the average breast weight based on body surface area, and that is the amount of tissue to be removed during the surgery. The most common surgical technique is known as the WISE pattern. The WISE pattern creates an inverted T-scar. This technique resects skin from the lateral, medial, and inferior aspect of the breast. This type of procedure can be done at any breast size and shape and allows for the transposition of the nipple areola complex without disruption of the nerve and blood supply. An alternative approach, though typically reserved for smaller breast volume, is known as a vertical reduction. This creates a scar around the nipple areola complex and then a vertical scar inferiorly. Given a portion of the tissue is removed just posterior to the nipple areola complex, there is often a larger risk of nipple necrosis or need for nipple grafting if blood flow is disrupted during tissue removal. Very large volume reductions or patients that have severe nipple ptosis can often not have their procedures completed in a standard fashion. In reductions involving extreme nipple ptosis, the nipple areola complex can often not be preserved and is subsequently removed, defatted, and then placed as a free nipple graft following a traditional WISE technique. And aside from typical surgical complications, infections are the most common, as glandular tissue often contains bacteria that cannot be sterilized. Additionally, fat necrosis, as Elena mentioned, is a really common complication that is often later seen on mammograms and requires a skilled radiologist to determine the difference between the cyst and the encapsulation of the fat tissue and a malignancy. Seromas and hematomas are often also a complication. Decrease in nipple sensation is a risk of any surgery, and in the case of nipple grafting, there is often a complete loss of nipple sensation. Patients may also later have difficulty with breastfeeding if glandular tissue is removed during the procedure, but often a reduction in breast milk volume is most common. If a patient is to undergo a procedure in which a nipple graft is placed, they will lose the ability to breastfeed in the future entirely, and patients should be extensively counseled on this prior to their surgery. There is also a common recurrence. However, the most common cause for a recurrence is actually inadequate volume reduction during the initial procedure. Transient hypertrophy, of course, is expected during pregnancy and weight gain, and true recurrence of hypertrophy is fairly rare, but happens more often if the procedure is completed during early adolescence. Recurrence of breast hypertrophy that is not otherwise explained should also have a thorough workup for an alternative etiology prior to referral back to the surgical specialists. The American College of Plastic Surgeons estimates that the patients demonstrate satisfaction with their procedure and improvement in their quality of life measures for greater than 90% of cases. 6 to 9 months after surgery, patients often demonstrate a significant improvement in their pain, as well as their ability to participate in physical activity. Patients also have a theoretical decrease in breast cancer risk due to the reduction of breast tissue. Additionally, rare cases of early malignancy have been detected on postoperative pathology examinations, and in these cases, patients should be immediately referred back to a breast oncology surgical specialist. For up to 6 weeks, patients should expect to wear compression garments and have strict activity and lifting restrictions. Patients may also be left with bulb drains, although this is no longer the standard of care for these type of procedures. Patients should also be counseled on wound care and expectations for the edema in their breast tissue to last as long as 9 months postoperatively. Routine mammography remains the screening test of choice regardless of breast size, and patients who have already undergone breast reduction mammoplasty by the time they come to see you should continue with routine screening intervals. So moving on to breast cancer mastectomy and reconstruction. The Women's Health and Cancer Rights Act of 1998 actually provided protection for women who elect to have breast reconstruction after their mastectomy. The act requires that payers provide coverage for all stages of reconstruction for the side at which the mastectomy was performed and surgical procedures to produce symmetry in the unaffected breast. Additionally, prosthesis and any physical complications such as lymphedema incurred as a result of their mastectomy are also required to have coverage. Patients may elect to have radiation and lumpectomy for the breast cancer, but due to complication and recurrence risk, many elect to have a mastectomy. These patients are largely who we're talking about today. Patients may elect to have no reconstruction following their mastectomy or choose to have an implant-based reconstruction or tissue-based reconstruction. The timing of reconstruction is also variable and dependent on several risk factors, including a patient's choice. If able, there are many benefits to having an immediate reconstruction following mastectomy. If a patient desires to maintain a similar size or has healthy enough vascularity, they can have an immediate reconstruction. At long-term follow-up, patients with immediate reconstruction have reported lower rates of depression and anxiety, as well as increased body image. There is also some thought that the absence of the additional surgical procedure in the future also aids in the satisfaction with their cancer treatment. Delayed reconstruction may be indicated for patients who are hoping for a significant size change or who have smaller breast volumes. Additionally, patients with poor vascularity or who will require extensive breast irradiation may require a delayed reconstruction with implantation of tissue expander, as cosmesis is greatly improved if the radiation is completed prior to the implant placement. In a delayed reconstruction, a flap with tissue is built and a temporary tissue expander is placed. The expander is filled with carbon dioxide and contains smooth walls to address the anaplastic large cell lymphoma risk. Expanders will then later be removed and replaced with a traditional implant. Patients who have had a delayed reconstruction report higher rates of depression, anxiety, and generally have a worse outlook on their cancer treatment success. And following a mastectomy or reconstruction, a patient's bra needs will also likely change. If a patient decides to undergo a unilateral mastectomy without a reconstruction, they can be offered a breast prosthesis. Patients may utilize bras with a created pouch for the placement of their prosthesis. And as the prosthesis and the mastectomy bra is considered part of the mastectomy treatment, the device and the bra may be ordered by their providers as DME product. Next, we'll move to gender-affirming surgery. So we'll briefly touch on gender-affirming surgery and the use of mammoplasty and mastectomy. And we won't go as in-depth on this topic as Dr. Loeb had previously done an incredible in-depth discussion in earlier grand rounds. Gender-affirming surgery is a critical step for many and is considered medically necessary in most cases. Gender-affirming surgery can alleviate the psychological discomfort many patients experience. Patients can undergo feminizing surgery using breast implants with techniques Elena discussed earlier. Patients may also undergo mammoplasty or mastectomy depending on the amount of tissue volume to be reduced and the degree of pre-surgical ptosis. Though it's not a requirement for hormonal surgery, insurance often requires a trial period of estrogen therapy prior to feminizing surgery coverage. With a mastectomy, the goal is often to remove the excess breast tissue as well as reposition and oftentimes reduce the size of the nipple areola complex. Though there are several techniques available, this will vary by surgical center and patient preference. However, there are some ongoing studies into the safety and cosmetic outcomes of each. Right now, the most common technique involves a peri-areolar approach, which involves cutting around the areola, reducing its size, and then the breast tissue is removed through the initial incision. As surgical treatment is considered medically necessary rather than cosmetic, it can often be paid for by insurance. However, as we see on this slide, the insurance criteria can often be a daunting checklist to tackle. This is not a standard example, but one that was provided by Aetna Insurance. And as you'll notice on this list further down, this payer requires 12 months of hormonal therapy prior to coverage of feminizing surgery. Following a mastectomy, transmasculine patients have a reduced risk of breast cancer compared with patients who have not undergone a mastectomy. The persistent risk of breast cancer depends on the amount of remaining breast tissue and family history. However, there remains a lack of quality longitudinal studies exploring the risk of breast cancer in residual breast tissue. There are also significant limitations of mammography after a mastectomy, and mammogram screening is not routinely recommended. Chest exams may be considered, though there is no consensus on the ideal frequency or the effectiveness of this approach. And additionally, if you do have a suspicion for a malignancy, ultrasound or breast MRI is the preferred imaging modality. Patients who have had estrogen therapy as a part of their treatment plan should also begin cancer screening at typical ages, either 40 or 50, once they have completed estrogen therapy for 5 years. They should continue with screening at recommended intervals. And then we have the breast cancer screening guidelines on the next couple of slides for your reference in the future. So this is breast cancer screening for trans feminine patients. And next, breast cancer screening recommendations for trans masculine patients. Our takeaway points. So we are all aware that our patients are having breast surgery. So it's really important to understand the complications as well as the implications on how to treat them in the future, as well as how this changes our routine breast cancer screenings. Patients should have a discussion about the treatment options as well as the implications of their macromastia as part of their normal treatment plans. You should also be asking their patients about breast health outside of their normal breast cancer screening discussions. And then also takeaway points, not to forget about our transmasculine and transfeminine patients and their need for continuing breast cancer screening as well. That wraps up our chat. If there's any other questions.
You indicated difficult, so is there sort of a way to gain that?
Yeah, so definitely if you write suspicion for a rupture, or if you document that they were in a car accident and there was trauma to their chest, usually insurance will cover for that. It's just sort of the screening asymptomatic patient per FDA regulations that's the most hardest to get covered.
There's a question here: can rupture implants be repaired unless they be removed?
Good question. So ruptured implants can't be repaired. That same implant due to infection risk, so that would have to be completely removed. And then it would be up to the surgeon whether to automatically replace that during that or to have some time for the breast tissue to heal before replacement happens. Dr. Kebby?
For the screening for rupture, that ultrasound or MRI, given the cost difference, is there any
Good question. So Dr. Kepi asked for screening for rupture, difference between ultrasound and MRI. So ultrasound and mammography is only about 30% sensitive for silicone breast rupture, while breast MRI, non-con, is more than 90%. So that would be the major issue. Definitely a lot cheaper to do the ultrasound, but much less sensitive. So another question we got was, can you discuss the role for in-office screening for these populations? So I'm assuming that means some screening, meaning some manual breast exam screenings. So it's actually very interesting when you look at data. We're very bad at detecting breast cancer on physical exam. They've looked at studies with physicians, OBGYN versus internal medicine, family medicine, trying to detect breast cancer just through screening breast exams in the office, and it's pretty poor. Definitely the longer time you take with the patient, and we're talking about 3 minutes per breast, which I don't think much of us do to begin with. It's actually pretty difficult to detect those. Definitely for rupture, clinically, it's very difficult to find a silicone rupture on exam. Definitely for all my patients who have silicone breast implants, if they have any trauma to their chest, we're usually doing further imaging to make sure we're not missing a rupture. Dr. Bolshin asked, what should we do preemptively before referring patients to plastic surgery for reduction? Is physical therapy required to document back pain?
Yes, so oftentimes insurance requires at least 3 months of a trial of conservative measures, which typically includes NSAIDs, weight loss trial, and then physical therapy prior to referral back to plastic surgery office.
Some plastic surgeons also have cutoffs for BMIs. So I think like for ours, it's 35. If your BMI is over 35, they won't give you breast reduction surgery.
Evidence of ruptured silicone implants that have been known thing. In other words, it wasn't surgically dealt with. Is this something that you feel like always needs to be dealt with, or is it like walled off and life seems like it's good enough? Because that was my recollection of this patient, that they were seen by a surgeon who's familiar with these issues.
Yeah, good question. So definitely it's not an emergency. So I think we see rupture on the MRI, we freak out, oh my God, something horrible is going to happen, got to see the plastic surgeon right away. So it's definitely not an emergency. I would say what plastic surgeons do versus what the FDA recommends is usually in some contrast. So in general, so the FDA would definitely recommend removal of that implant. Breast surgeons will usually have some risk benefits discussions with the patient. Maybe they'll follow the rupture. But the concern for that is any type of silicone that sort of invades into the bloodstream or things like that could lead to complications in the future. Just like in the past when we'd see sort of off-use silicone sort of given on the streets or in other clinics for cosmetic purposes and the consequences of that. Yes, Rita. Breast implant illness? Mm-hmm.
Yeah. That there is some improvement with one of the figures, but what percentage of that is due to allergen, is that removable?
Yeah. So Rita asked about prognosis of removing breast implants for patients with concern for breast implant illness. So unfortunately, there's like literally no data on this because there hasn't been actually studied. Anecdotally, and especially on this Facebook page, is actually very fascinating. Most patients who have their breast implants removed, at least in the acute period, report very significant relief of their symptoms. Chronically, that doesn't seem to be the case. 3 to 6 months later, things come back. But overall, it seems like they have pretty good feeling after that.
The FDA recommends removing implants in a decade or so. To me, that seems like a kind of minor thing, but it feels like that would be tremendous.
So Brandon's asking about removal of implants after this sort of the 10 to 15 year mark and replacement. So I'll say for most of my patients, the concern is just that the rupture risk of 15% per year after 10-year implant is the concern of why FDA, I think, wants removal and placed back in. I will say for most of my patients, when they check back in with their surgeon 10 years later, the surgeon says, if you're having no problems with your implant, we're just gonna keep it rolling. We don't have to do that. So for most surgeries, anything under the muscle obviously is a bigger issue. If you already have a pocket though under the muscle, like we're not going from a subglandular to subpectoral, the implant replacement is actually not that bad. If you watch botched or any actual surgical procedures, it sort of looks scary and painful when they pull the implant out because it's usually a very small incision they make to pull the entire silicone implant out versus a saline. And then they will basically try to jam it back in. So as long as you're not changing your size significantly, usually it's a pretty decent, looks like 4-hour procedure. Stay overnight in the hospital and then come home the next day. All right, so I think that's all the questions we have. We'll stay on here if anyone has any other questions on the chat or in person, but otherwise, thanks so much. Yeah.
Sorry for the meltdown. That's part of the process.
Now we know. I'm glad the pull everywhere worked.
Yeah.